The following podcast is part of a certified educational activity titled Innovative Therapeutic Concepts for Autologous Stem Cell Transplant Eligible Patients with Myeloma, Advancing Toward More Effective Care Across Treatment Settings. Access the entire activity and complete the post-test at peerview.com/QAJ. Downloadable slides and practice aids are also available.
Well, I'd like to welcome everybody to this early morning session. I'm joined by my colleague, Dr. Orlowski from MD Anderson Cancer Center, and I'm Sagar Lonial from Emory, the Winship Cancer Institute in Atlanta, Georgia. And we're going to talk through these ideas of innovative therapeutic concepts for transplant-eligible patients with myeloma and really break it up into two big sessions, and we'll talk about the agenda as we go forward. Again, we'd like to make sure we thank the Medical College of Wisconsin and Peerview Institute for developing this educational event, and to our supporters that you can see listed there for providing educational grants that really allow this symposium to occur. I think it's important to put where we are right now in the context of historical therapy for myeloma. So prior to 2005, I think it's fair to say that we were in what I would call roughly the dark era of myeloma therapy, where we didn't have a lot of things, or we had just gotten bortezomib, we had just gotten thalidomide and lenalidomide, and what we were trying to figure out is how to combine these drugs to really make a difference. And between 2012 and 2018, we saw the approval of many new drugs, second generation agents as well as the ability to assess things like MRD to much lower levels of depth than we've previously been able to do. And what I think we're looking to in the future now is how do we combine these together? How do we use immune-based therapy, which is the rage across all of oncology? And how do we use novel targeted agents that work intracellularly to really combine and ultimately increase the cure fraction of patients with multiple myeloma? So the agenda is we're going to, as I described earlier, is really two sessions. The first is going to be the march of next generation agents and antibodies into pre-transplant or induction regimens, as well as the role of MRD. Dr. Orlowski will cover that. And then I'm going to cover relapse disease in the post-transplant context with updates on novel platforms and the coming wave of new agents that are coming down the pike very shortly as well. And to get us started, Dr. Orlowski is going to talk to us about induction therapy.
Well, thanks very much, Sagar, for the introduction and for the opportunity to be here, and wanted to welcome all of you to Houston, Texas, and hope y'all enjoy yourself while you're here. My job will be to tell you a little bit about options for induction therapy, and then we'll cover as well things about MRD and maintenance. So here's a model for how transplant-eligible patients are currently treated. Of course, you first have to diagnose and risk stratify people, and those who are symptomatic will typically undergo some kind of induction therapy. Then intensification or consolidation, which may be with high-dose therapy right now, maybe with other things in the future, and then eventually go on to maintenance. And the hope is that you're reducing the amount of disease burden with each of these therapies. Generally, the principles of that approach are shown here. For people especially who are healthy and robust, triplets are probably the current standard of care. In the US, RVD would be probably most commonly used, but in some cases you may use Cyborg-D. Carfilzomib Lendex may be appropriate if bortezomib Lendex is not considered, and maybe in the future you could consider all oral therapy such as Ixa Lendex. Doublets probably would not be used too commonly, although if you have a patient with poor performance status or if they have renal dysfunction, it may be appropriate to start off with a PI and a corticosteroid and then later add an IMiD. And then in maintenance, certainly the standard is lenalidomide. Probably if you have high-risk disease based in part on data from Sagar's center, you might want to combine a PI and an IMiD, and that could be either with bortezomib and len or maybe Ixa and len for high-risk patients. In terms of RVD as the standard, probably the best study demonstrating that was the SWOG SO777 trial that compared RD to RVD. And this was a combination of patients who were transplant ineligible, as well as those who were eligible but were willing to defer transplant. And you can see that there was both a progression-free survival improvement as well as an overall survival improvement for the PI-containing regimen. So that really gives you the rationale to use RVD. Next question is, what consolidation should you do? And the IFM trial that was published now a couple of years ago essentially used RVD induction in both arms, randomized patients then either to get early transplant versus just stem cell collection and no transplant, followed by len maintenance. This was the French arm of the study because it was for only 12 months. And you probably know that there was a better progression-free survival if you did upfront transplant, but overall survival so far has not been different, and we're eagerly waiting for the results from the US half of the study, which did len until progression as maintenance and not just for 12 months. But in general, the meta-analysis of a number of these trials do suggest that lenalidomide as a maintenance is preferred, and you can see pooled data here favor lenalidomide by quite a nice hazard ratio compared with placebo. Recently, this was highlighted by the Myeloma 11 trial, which looked at len maintenance post-transplant, which again shows with a highly statistically significant p-value that people have a better outcome in terms of progression-free and overall survival if you give them len maintenance. And this was almost a doubling of PFS. And also, although the improvement in high-risk patients was a little bit less than in standard risk, even the high-risk patients did benefit from len compared with placebo. Another question that sometimes comes up is, should you do a single transplant or a tandem transplant? And more recently, this has been really looked at because of the European data that suggested, especially in high-risk patients, maybe a tandem is better. But it's useful in that regard to look back at the Stamina trial, which I'm sure you remember looked at different consolidations after stem cell transplant, with one arm that was essentially a second transplant and then len maintenance. A second arm was RVD consolidation and len maintenance. And a third arm was essentially no consolidation, moving right on to len as a maintenance. And these data did show that there was no significant difference in PFS as well as in OS, but remember that these were patients that were not necessarily stratified based on response prior to therapy. So let's look at some of the data for, in particular, antibodies as well as other agents in the upfront setting. First, we talked about VRD as a standard, but KRD is liked by many people. There is an ongoing ECOG trial which is comparing VRD to KRD, which has completed enrollment, but it will be a little while before we have the randomized data. So in the meantime, the data that we have are from single center or posse center studies, but not randomized trials yet. You can see in this trial where they used KRD as induction, transplant, KRD consolidation, and then len maintenance, that you do have an improvement in the stringent CR plus CR rate after transplant, then after consolidation, and then as the best response, you can see further improvement with all of these therapies. And 70% of patients were able to achieve MRD negativity by flow, which is quite high and very encouraging. Another useful trial to look at was recently reported at ASH, where they did essentially Cyborg-D, but with carfilzomib instead of bortezomib as one arm. And then the other two arms were KRD. All patients got mobilization. These two arms got a single transplant and then consolidation, Whereas here, there was no transplant, just the consolidation, and then out back there was randomization to either R or KR as a maintenance. And this is the pre-maintenance response summary. So you can see, for example, after transplant or 8 cycles of KRD, that the folks that got KRD were better in terms of response rate and response quality than the people who got K with cyclophosphamide and Dex and transplant. And there also was a trend towards a higher rate of MRD negativity here in the green bars if you got KRD at some point, as opposed to if you got the cyclophosphamide version of that regimen. One slightly helpful data set that was reported at ASH came from Ola Langren, and this is a registry study, so it's retrospective data, not prospectively randomized, but using the COMPASS data set, they compared outcomes of people who got KRD versus those who got VRD, and there is a suggestion that there may be a better outcome in terms of event-free survival if you got KRD for all patients, which included those who were transplant eligible or transplant ineligible. But again, we need the randomized ECOG data to be really sure. One thing to remember when you're using carfilzomib is that there may be a slightly higher cardiac risk factor signal with this drug. This is especially true probably if you have older patients that are not eligible for transplant. So in the folks that would be eligible, probably less of a concern, but it's still recommended that you closely monitor them for clinical signs or symptoms of ischemia or CHF, and of course withhold the drug for any grade 3 or 4 events, and think about whether you should restart or not. If you do, it should be probably at 1 dose level lower than the initial dose of carfilzomib. Other proteasome inhibitors that you could use include ixazomib with Lendex. The benefit here is that, of course, this is an all-oral regimen, and we know again that if you do IRD and then transplant followed by ixazomib maintenance, you do have an improvement in the CR rate the longer you're able to stay on therapy. And we are anticipating soon seeing upfront IRD data from one of the randomized tourmaline studies in the transplant ineligible patient population. Also, daratumumab has been added to IRD in newly diagnosed patients. There were actually a couple of abstracts looking at this at ASH, but here was one of them where essentially ICSA was given day 1, 8, and 15. You get lenalidomide for 21 out of 28 days. You get weekly Dex as per usual. And then, of course, the daratumumab, which is weekly for the first 2 cycles, and then every other week after that, followed by maintenance with ICSA and DARA. And you can see a VGPR or better rate of almost 70% as the best response, which is quite encouraging and certainly shows that daratumumab is kind of like bacon. You know, everything is better with bacon. So same thing in myeloma therapy. Anything that you add daratumumab to will probably be better. One study in terms of maintenance that you may want to consider that was also presented at ASH and has since been published looked at, instead of len as a maintenance, thinking about ixazomib. This was at 3 milligrams on days 1, 8, and 15, and then later on, if it was well tolerated, cycles later was at 4 milligram, and this was a comparison to placebo. And you can see in terms of progression-free survival, there was a more than 5-month improvement giving oral ICSA. And as you would expect, if you were MRD negative, you did better whether you got ICSA or placebo. But the best group, of course, was the people who got ICSA and achieved MRD negativity with a median progression-free survival of almost 40 months. This is the response summary. So you can see that adding ICSA did increase the number of patients whose response quality improved. including patients who went from VGPR to CR. This was with placebo, so of course it shows that transplant by itself over time, you do need a little bit more time to see the maximum benefit than just 3 months out, but adding ICSA improves that rate, and also people did convert from MRD positivity to negativity on this study. Safety-wise, if you've given ICSA, you probably know that the major issues that you see are thrombocytopenia, although most of that is not severe in grade, and also GI effects, which can include nausea, diarrhea, and vomiting, and occasional arthralgias. Otherwise, it's a very well-tolerated drug overall. And so in general, the feeling is that it does improve progression-free survival. You can see an almost 40% improvement. Quality of life was maintained. There was a low risk of patients discontinuing therapy. And so further investigations of this are definitely warranted. And you should especially think about this for people who maybe are IMiD, like LEN, intolerant because of things like cytopenias or potentially diarrhea. Other combinations for upfront that you could think about, so daratumumab with KRD may be something to consider. Once again, you can see that after 8 cycles and as best response, you're achieving 90% plus patients with VGPR, so definitely a regimen to think about. And long-term outcomes in terms of surviving without progression look quite good as well, with 94% 12-month PFS and 100% overall survival, and no impact on stem cell collection. One of the randomized studies that we're hoping to get data from about adding DARA in transplant-eligible patients is the so-called Griffin Trial, and Pete Voorhees presented mostly safety data at ASH, but this is a trial that is essentially looking at RVD versus DARA RVD as induction, followed by transplant in both arms, and then the RVD arm gets R maintenance, whereas the RVD DARA arm gets daratumumab with R maintenance. And again, these were all toxicity data, but you can see some risk of neutropenia and febrile neutropenia, but nothing unusual for patients getting RVD plus minus DARA and transplant. Non-hematologic adverse events are shown here. There were episodes of pneumonia, but this is only a small data set of 16 patients, so I think this 25% rate will probably come down. And in terms of these infections, most of these were upper respiratory, although there were a few pneumonias and one episode of bronchitis, and there was a low risk of infusion reactions, most of which were grade 1 and 2 and easily managed. And here are the response data. You can see 94% overall response rate at the end of induction, which went up to 100% after consolidation, and stringent CR rates of as high as 63% during the maintenance, and this number will probably improve further as people get deeper into that maintenance portion. There also will be data coming out from the so-called Cassiopeia trial, which was essentially VTD transplant, VTD consolidation versus VTD DARA as induction, transplant, VTD DARA maintenance, and then an out-back randomization to either observation or daratumumab. So I think the take-home messages in terms of induction and maintenance are summarized here. In the US, probably VRD and KRD are the major standards of care. Sometimes, and particularly in Europe, VCD and VTD are the current standards. And in the short term, we could definitely see adding daratumumab either to all patients or potentially at least those with high-risk disease who are still not doing as well. And in the long-term, possibilities may be 5-drug regimens that may be molecularly adapted, for example, adding venetoclax for 11-14 patients. In the maintenance setting, R alone is the standard if you've got good risk disease, whereas if you've got higher risk disease, VR plus or minus DEX, and maybe ICSA-LEN, although we still need more data about that before adopting it. In the short-term future, adding daratumumab may be an option. There will be a Swab trial that will look at R versus R-DARA as a maintenance. And then at 2 years, there will be a second randomization so that if you're MRD positive, you continue. If you're MRD negative, you'll get randomized to either stop maintenance or continue. And that will answer the question of whether with better maintenance and you get to MRD negativity, maybe you can stop therapy. In the long term, it may be that BiTEs may replace maintenance, and also maybe CAR T cells will be something that will be looked at instead of stem cell transplant, and one could particularly envision these in high-risk patients. And then a couple of thoughts on MRD assessment. The NCCN, you may know, now includes a recommendation that MRD assessment should be part of the post-transplant evaluation, and this should be done either by next-generation flow or next-generation sequencing, potentially both. These are some of the reasons why MRD negativity is important. You can see even in patients who achieve CR, if you are MRD negative, you have a better progression-free survival than if you are MRD positive, and this is by almost 2 years, so that's quite a nice difference. Now, you do still have a risk of relapse, even if you're MRD negative, and that means we need even more sensitive measures of MRD than what we have right now. But MRD negative gives you a better PFS, and also you can see a better overall survival. So if nothing other than to give the patient and their family the most up-to-date information about prognosis, MRD assessment is definitely worth doing. Here you can see data from the IFM trial, which show that once again, progression-free survival from the start of maintenance. If you're MRD negative, you do better. And the same thing after 12 months of maintenance. And remember, they stopped len maintenance after 12 months. You still do better if you're MRD negative than if you're MRD positive. So MRD assessment with next generation agents, this was a study looking at the benefit after IRD. And again, if you were MRD negative, which wound up being a good proportion of patients, that was something that led to a positive benefit. And ultimately, what we really need are randomized data. So you may remember the first version of the determination study, which was the IFM and then the US trial that looked at RVD as an induction in both arms, and then early transplant in one arm, followed by maintenance versus no early transplant. There is a plan for a second determination study, which will look at MRD negativity as an endpoint. And if you're MRD negative, they will look at whether transplant may be able to be delayed and go to consolidation instead. Whereas if you're MRD positive, there will be a randomization to 2 different lengths of additional therapy before moving on to transplant. So this will really give us important data about how not just to use MRD as a prognostic tool, but maybe how to make decisions about additional therapy. And then I mentioned briefly the Swab trial, which is outlined here. This will probably open in May of this year, fingers crossed. What we hope to do is randomize patients after transplant to either DARA and len versus len. And then at 2 years, as I mentioned, if you're MRD negative, you will either continue or discontinue maintenance, whereas MRD positive patients will all continue on their assigned maintenance. The MRD take-home messages: MRD negative patients do better. That's not, of course, surprising. Less cancer is always going to be better than more cancer. When you're assessing MRD negativity, that's really a benefit right now for patients and their families in terms of prognosis. Achieving and maintaining MRD negativity is great for everybody, but probably even more important for high-risk patients. And I think the still open question is whether intensifying or consolidating people who are MRD positive to get them to MRD negativity will improve their outcomes.
Thanks, Bob. I think that was a really good intro into the plethora of data that's out there on what to do in the context of induction therapy. And as Bob alluded to, the CTN trial recently was completed and actually I think was just published in JCO and demonstrated that there was no difference in consolidation whether you did a second auto, whether you did RVD consolidation, or you went straight to maintenance therapy. And this is in distinct difference to the European study, which I think really has to do with the availability and access of drugs as well as the choice of induction. And so I think I would echo what Bob said in the sense that what we use for induction therapy really can impact short and long-term outcomes for patients. And just to highlight that point, I want to show you data that Dr. Nuka from our group has actually presented at ASH recently with 1,000 patients who all received RVD induction. And while we're all waiting on determination to tell us what the absolute benefit for continuous len maintenance is versus the 1 or 2 years of maintenance that was in the IFM study, we can sort of give you a clue. It looks like it adds about a year of progression-free survival for all patients in aggregate. And I think the keys here are that with a planned risk-adapted approach in the maintenance setting, you can actually significantly improve PFS and overall survival in a large population-based approach. Now, when patients do relapse, what are the patterns of relapse? And it would be really interesting to compare this data with what we saw probably 20 or 30 years ago, because as you can see, some of the more common things that occur really are, in terms of developing CRAB criteria, are lytic bone lesions, plasmacytomas, or the development of anemia. But almost 2/3 of patients who present with relapse now are presenting with biochemical-only relapse, because we're watching patients far more frequently than we used to, particularly patients who are on lenalidomide maintenance or being seen every month, every other month, or every 3 months, as opposed to the historical way of following these patients where you didn't bother them if they weren't bothering you, and you waited until something significant really showed up. Now, I think there still remains a controversy, and in fact I've been in a couple of debates with my colleagues all over the world regarding when to initiate therapy in the context of biochemical relapse disease, or relapse disease in general. And the current guidelines from the International Myeloma Working Group do continue to say that CRAB criteria is something you want to look for in patients. And I don't know that we want to necessarily say we want to stick to the letter of that law, but certainly watching patients and their tempo of relapse is not uncommon, and it's actually something that we do quite frequently. Now, patients that have rapid rises in their M protein, there's no reason to wait for CRAB criteria. You can initiate therapy. Patients who you know, when they get high levels of light chain, develop renal failure, makes sense to intervene on those patients early as well. And then patients with high-risk genetics, who you know go from 0 to 5 grams in 60 days, no reason to wait on those patients. But for the average standard risk myeloma that's progressing on single agent len maintenance with a protein of 0.2 or 0.3, I think one can be patient and watch them and get a sense for what the tempo of that disease is. Now, one of the things that I do differently now than as opposed to 10 years ago is when I see biochemical disease, I'm pretty quick to get imaging. Because I think one of the things that we will often miss with a low-level biochemical disease is the development of occult bone disease, which a skeletal survey typically will not pick up. But the use of PET imaging allows you to find those patients who you shouldn't sit on, who you should probably go ahead and initiate therapy early, and it's a way to provide some comfort both to you and the patient that watching and waiting is not necessarily going to cause them any harm. Now, what are the options in the context of relapse disease? Well, this is data from the British group and Gordon Cook demonstrating the use of a salvage auto versus standard therapy in the MRC setting. And while it does show an improvement in progression-free survival, the comparator arm in this was basically cyclophosphamide and prednisone. And so I think, to me, the use of salvage high-dose therapy and chemotherapy really is reserved for patients that have very long durations of remission. And remember, if you're using len maintenance, according to the IFM study, the median PFS is 48 months. So for me to really get excited about a second transplant, I'm looking at somewhere between 4+ years of remission on lenalidomide maintenance in order to really be excited about the idea of a second auto. Where we are more commonly using second autos now is in patients who've had myeloma for 5 years, 6 years, 10 years, and their counts are low. And you can't treat them with anything because their white count's 1.5 and their platelets are 45. You can't even enroll them on trials. In those patients, use of salvage auto may not give you a long duration of remission, but it will jumpstart hematopoiesis and allow you to treat them again on or off a clinical trial. Now, what are some of the regimens that are available for patients with relapsed or refractory myeloma? These are the Nccn Guidelines, and you can see the category 1 basically are a series of triplets, for the most part combining with lenalidomide and dexamethasone. The one outlier here is the carfilzomib data that's there, and then 2A is bortezomib, lendex, and carfilzomib weekly with dexamethasone. But I think we should really talk more and focus more on the role of triplet-based therapies. And this is a nice summary slide. I'm sure many of you have seen these presentations over time that really shows you the spectrum of data in the context of relapse disease, most of which are based on a lenalidomide backbone. And I will tell you personally, I struggle with what to do with all of these lenalidomide backbone phase 3 trials where it's 3 drugs versus 2, clearly an improvement in PFS, in most of them an improvement in overall survival, but none of the patients in these trials received lenalidomide maintenance or long-term lenalidomide therapy. Whereas most of our patients right now are on lenalidomide maintenance. And so I think I find these interesting. It's randomized phase 3 data, the highest level of evidence you can have, but I don't find them as relevant for my patient in the clinic as I do some of the bortezomib backbones, the carfilzomib backbones, or potentially even the pomalidomide-based backbones. And again, you can see the hazard ratios and the PFSs listed here in this slide. So what are some of the updates on triplet-based therapy? Well, this is the Tourmaline MM1, and I think it's really interesting to break down PFS by the presence or absence of NF-kappa B mutations. And we know, for instance, from old bortezomib-based therapy that NF-kappa B2 mutations or NF-kappa B pathway mutations like TRAF2 or TRAF3 can actually enhance sensitivity to bortezomib. Leon Bernal from our group has identified that NF-kappa B2 mutations may actually predict for exquisite sensitivity to proteasome inhibitors, and we're testing that in a biomarker-driven trial. And what you see here is that patients who did have mutations in NF-kappa B that conferred sensitivity to proteasome inhibitors actually had the best PFS, and the worst PFS was in the lendex arm where those mutations were also present. So the IMiDs don't seem to be able to overcome some of that mutation-based data. What about the CASTOR data? This is 2-year update on DARA plus bortezomib dex. Again, you can see with longer follow-up, the curves continue to remain separate, showing a significant benefit for the addition of DARA to bortezomib dex versus bortezomib and dex alone. And remember, most of these patients actually stop the bortezomib somewhere between 8 and 12 cycles. So this really is demonstrating the benefit of daratumumab maintenance in the context of relapse disease. And of course, the longest PFS we've seen in any randomized trial in relapsed myeloma is the Pollux trial, and now with 3-year follow-up, it looks like we're starting to see that curve hit the median PFS range here, somewhere around 44 months. Not only does that occur, but the overall response rate is continuing to be higher for the group that got DARA, and the MRD negativity rate is higher for the group that got DARA as well, although again, a caveat here is that this was using 10 to the minus 5th as the measurement of MRD, not 10 to the minus 6, which I think Bob and I would agree for the most part is probably the more important MRD negativity benchmark when you're comparing across trials. Now, what about using pomalidomide? And this is actually something that's moving earlier and earlier in the disease course now because patients are progressing on len maintenance. And so if you want to use an IMiD-based approach, going back to len probably does not offer as much benefit as switching to a different IMiD that clearly can overcome len resistance in subsets of patients. And this was the Aquelis trial, which was a part of the 1001 trial, which enrolled 103 patients with relapsed myeloma. again, median age was about 64, and showed an overall response rate, or VGPR or better rate, of about 28% using daratumumab in combination with pomalidomide. Now, the challenge in this is that this trial enrolled patients with lots of prior therapy, because this trial was really early on in the daratumumab experience, and many patients had had 2, 3, and 5 prior lines of therapy before they came on this study. So just to give you a sense for what dara-pom-dex can do in an earlier relapse, this is data that's in press from our group looking at a series of only 34 patients. So it's not as big as what we saw from Aquilas. But if you look at cohort 1, which was our group of patients that were POM and dara naive, the PFS and overall survival for these patients is actually quite good. Median PFS has not been reached, with a median follow-up of about 41 months. And these were almost all first relapse patients. So again, speaks to the idea of using dara with a different IMiD in the context of early relapsed myeloma. Now, what are the adverse events associated with monoclonal antibodies? Well, the one that's probably most commonly seen is infusion reactions. And you can see here in terms of what are recommended pre-medications. I will tell you the use of Montelukast really, I think, has changed the spectrum and the severity of infusion reactions. Our group has published on that as well, with the addition of Montelukast versus not. It actually shortens the duration of that first infusion by about 2 hours on average, and it reduces the severity of the infusion reaction by 1 full grade. So I think recommending the use of this aggressive first infusion approach makes sense. You can see what's recommended for Elotuzumab on the right there, a little less intense. Infusions occur with a relatively similar, perhaps slightly less intensity and less frequency, but in general, infusion reactions tend to be the most common adverse event that's seen there. Now, what about newer second-generation CD38 antibodies? This is Elotuzumab, which does have some slight differences in terms of how it may work, in terms of its mechanism. There are a number of different pathways that have been implicated, both for dara and for ESA, that are outside direct anti-tumor effects, and these are some of those that are listed for Elotuzumab. At least in the laboratory, there's suggestion that some of these NK and macrophage activation may be an important part of Elotuzumab. There was data presented at ASH on the combination of ESA plus POM-DEX in a late relapse setting. This was a standard 3+3 dose escalation. And again, if you begin to look at the frequency of infusion reactions associated with Elotuzumab, most predominantly occur with the first dose. Same thing we see with dara and with Elo. And unless it was anaphylaxis, you probably can continue on, and the frequency continues to reduce with subsequent infusions over time. If you look at response rates, this is the ESA POM-DEX response rate. Again, about 60-ish% of patients had a response. The 10 milligram per kilogram dose was likely the one that's going to be used overall. And again, not dissimilar from what we saw in the dara POM-DEX data. Median PFS was about 17 months, which was longer than we saw with dara POM-DEX, but this was an earlier patient population compared to the Aquilas data that I showed you before. What about ESA as a single agent? This is data on ESA or ESA plus DEX, suggesting that there may be more than an additive benefit with the addition of dexamethasone. Again, overall response rate of about 44% for ESA in this current dose and schedule. There is now data emerging with ESA plus carfilzomib with an overall response rate of about 60%. And even in double refractory patients, we're seeing an overall response rate of about 58%. So ESA clearly is another option that can target CD38 and combines well with other drugs. And there are ongoing trials really testing this. This is probably the approval trial that's, I think, completed enrollment now, which is ESA POM-DEX versus POM-DEX, a randomized phase 3 trial, greater than 2 prior lines of therapy, and we're waiting on results of this in terms of when we'll see data.
As Dr. Loniel notes, data from the phase 3 ICARIA study testing the addition of isatuximab to a pomalidomide dexamethasone backbone versus doublet therapy are forthcoming. Although evidence from this trial has not yet been formally presented, the primary endpoint has been met.
There are also other trials ongoing in Europe. This is a German study looking at isatuximab added in to RVD in a randomized fashion within maintenance with len plus ISA versus lenalidomide. Again, this is not completed enrollment yet, and we're anxious to see that data going forward. Now, as we continue to talk about antibody-based targets in myeloma, one antibody target that I think to me represents one of the best targets in myeloma is BCMA, B-cell maturation antigen. And the reason that I'm so excited about BCMA is that it is expressed on a narrower spectrum of cells than you see, for instance, with CD38 or even with SLAMF7, as we know, or CS1, as we know for Elotuzumab. And again, I think this really does represent an important potential step forward. And so there are a number of ways that are being tested now to look at BCMA as a target in myeloma, including a BiTE. And Bob referred to a BiTE earlier on in his induction talk. This was data presented at ASH from the German group looking at an anti-BCMA bispecific T-cell engager, so blinatumomab for myeloma, if you will. I think what we saw was that there were, in fact, responses that were seen. There were really deep responses that were seen in some patients as well. And I will tell you, personally, I was a little skeptical about whether this was going to work in myeloma. Not because I didn't think it's a good concept, but I was worried that the T cells in a refractory myeloma patient were not healthy enough to really engage a BiTE to allow it to be effective. But clearly when they hit the right dose, they did see responses. Those responses were quite deep. They did see a little bit of CRS, not typical for what you'd see with a CAR T cell, but they did also see some interesting neuropathy, which is unclear in terms of its etiology, and larger studies are currently ongoing, not just with this one, but with long half-life BiTEs. And as you recall with Blina and with this one, they're continuous infusion therapy. And in the myeloma world where patients can take a pill and go back home, continuous infusion can be a hard sell for many patients. And so figuring out how to give it in a more patient-friendly schedule is the current target of many studies looking at BCMA-directed BiTEs. What about a BCMA antibody-drug conjugate? This is the GSK 916 monoclonal antibody that's been presented in phase 1 and an expansion cohort of patients as well. If you look at the refractory myeloma patients treated at the highest dose level, the response rate was 66%. And if this holds up in a larger trial, this would be the highest response rate of any single agent in the context of myeloma. The most common side effect we saw with this was corneal toxicity and hematologic toxicity. The corneal toxicity is related to the payload, the antibody-drug conjugate, that is a cousin of what's seen in brentuximab, slightly different. And again, neuropathy is not the big issue. There is some corneal issues. We're waiting on a larger cohort of patients in what we hope will be a registration study that has completed enrollment to get a sense whether this is ready to move forward for FDA approval. And the other one that most people, I think, are really excited about, I can tell you every single patient walks in the door asking about, can I get a CAR T cell, even when they have smoldering or MGUS? And this was data on the anti-BCMA CAR T cell, BB2121. And again, remember, patients get leukapheresis, manufacturing, bridging therapy was allowed, they get Flu-Cy for conditioning, cell infusion, and then watched over time. And as you've seen with other CAR T cells, patients respond. Not a big surprise. The response rate is actually quite high for this and for many other CAR T cells. And then if you begin to look at response by BCMA expression, perhaps a slight difference, but I think the real issue here is that the BCMA antibody we use to check for expression is not a very good antibody. And so knowing what that really means is hard in the context of the fact that almost all myelomas express BCMA to a certain level. If you look at patients that develop CRS in this phase 1 experience, about 2/3 of patients developed some level of CRS. None of them were grade 4, and most of them, again, were relatively manageable with either observation, tocilizumab, or corticosteroids. And the average time to developing CRS was about 2 days, between 2 and 6 days was the average time to get it. What about other CAR T cells that are out there? Well, there's the L-CAR, the J-CAR, the P-BCMA CAR, and the M-CAR. And if you want the Cliff's Notes version, the response rates are almost the same across all of them. The CRS rates are almost the same across all of them. What we don't know about is durability of response. And that really becomes the main point for all of these CAR T cells in myeloma. What's the median PFS? How long will they last? And are these subtle differences in vectors or co-stimulatory molecules enough to make a difference in long-term PFS? And we just need more data to really address that question. So what about other intracellular targets in myeloma? Immune therapy is great, but there are other targets to potentially go after, and the two I'm going to touch on briefly are venetoclax and selinexor. Venetoclax, I think most of you are fairly familiar with, targets BCL2, is approved in lymphoma and in CLL, and there clearly are subsets of patients with myeloma that look more lymphoma-like, particularly the 11-14 subset that are more sensitive to venetoclax. Selinexor is another drug. It's a new class, the EXPO1 class of agents. It works by impacting nuclear translocation of oncogenes and is, again, as I said, a brand new target in myeloma and in cancer in general, and is one that we're very enthusiastic about, and I'll show you why in a moment. Venetoclax in relapsed or refractory myeloma, this is the safety data, not dissimilar from what's seen in CLL or lymphoma. Nothing really jumps out at you. What I will tell you is that different from CLL, the incidence of tumor lysis syndrome is much lower in myeloma than it is in the other diseases. Doesn't mean it doesn't ever happen. We've actually seen a couple of cases of very mild tumor lysis syndrome, but it doesn't necessarily require that ramp-up dosing that you often see with CLL or lymphoma. And if you look at venetoclax in combination with bortezomib dexamethasone, clearly a very active partner. The single agent activity of venetoclax in myeloma is about 30 to 40%. When you add dex, it jumps to about 60%. And these are patients who are 11-14 positive and 11-14 negative who had responses when partnered with bortezomib as well. And if it works with bortezomib, you know it's going to work with carfilzomib as well. This is data by Dr. Costa and his group combining it with carfilzomib and dexamethasone. And larger trials are really needed to understand what that means, because many of these patients were carfilzomib naive. And so how do you tease out what the benefit of venetoclax plus CAR is versus the benefit of carfilzomib alone in a relapsed myeloma patient? So the data we're all waiting on is this phase 3 trial, the Bellini trial, combining ven plus bortezomib dex versus bortezomib dex in relapsed and refractory myeloma. Hopefully this trial will read out in this year, and that will tell us whether across the board venetoclax and bortezomib benefit all patients, or is that benefit limited almost at least right now to the 11-14 subset of patients. And so I think that's an important endpoint for us. Now, as I get to the selinexor data, I think it's important to understand what is the overall survival for refractory myeloma in the daratumumab era. And this is a series of about 134 patients from our center, almost all of whom are penta-refractory, have seen all of the big 5 agents out there, a majority had high-risk disease. This is about 134 patients in this series, and most of them had seen DARA right before they came in. And as you can see, the median overall survival for this patient population is about 11 months. It's not very good compared to where we were. It almost represents the double refractory patients from 5 or 6 years ago, before we had all these new second-generation agents and monoclonal antibodies. And so this is where the STORM trial with selinexor really comes in. This is selinexor plus dexamethasone and was initially presented at ASH and has been updated more recently. Overall response rate in 122 patients is about 26.2%, with a couple of patients actually achieving a stringent CR. Median duration of response across all the patients was about 4.4 months, with median PFS of about 3.7 months. Now, if you start to look at toxicity of selinexor, again, in a penta-refractory patient population, so these are patients that have seen every available drug that's out there, the most common occurring greater than grade 3 adverse event is hematologic, and that's predominantly thrombocytopenia. GI-related issues, nausea, vomiting, diarrhea, weakness, fatigue, and hyponatremia. And so there are some recommendations on how to get patients through that first few cycles of selinexor while you're trying to see if they're going to respond. And again, some of those are listed on the right side of the slide here as ways to try and aid in terms of supportive care for getting patients through those first couple cycles to give them the best chance to respond to a drug that works when most other drugs really don't work at all. So really figuring out how to give it in myeloma, I think, is important because, again, many of these patients don't have other options. In terms of where selinexor is active, again, where I think I'm really excited about is combining it with proteasome inhibitors. Both the bortezomib and the carfilzomib data overcome resistance to both those agents with the addition of selinexor. There is a phase 3 trial that's now enrolling or about to be completed in terms of enrollment that will address this in a randomized fashion. And again, it clearly has activity in a relapsed and refractory myeloma patient population. So to sum up, again, I think clearly triplet therapies are preferred regimens in the early relapse setting. I think it's hard not to use DARA in an early relapsed patient population, and the question is, what's the partner for DARA in this situation? Again, they're antibody partners with IMiDs and with proteasome inhibitors, and they're novel classes that clearly offer significant benefits, such as BCMA-directed therapy, whether it's antibody drug, BiTEs, or CAR T cells, as well as XPO1 inhibitors and BCL2 inhibitors over time.
So we have a couple of questions here, and Sagar, this was an area that you covered, so I'll give this to you. It's, when do you start Montelukast? Do you follow up with first-time infusion protocol on the second infusion if they react? And do you change anything if they have a smoking history?
Yeah, so those are good questions, and I think the Montelukast is started on the day of the first infusion, so you give it probably an hour before they're going to start, and we usually continue it for the first cycle, so for those first 4 doses, and then we usually stop it after that. You can continue it, there's no downside of continuing it, but I think they usually don't need it after that first 4 doses of therapy. So that answers, I think, both the first and the second. Do I change anything in patients with a smoking history? I think it really depends on how bad their smoking history is. I mean, they were excluded from the early phase studies because of the concerns of, and it turns out basophils also express CD38. So a lot of that early upper respiratory sinus stuff that patients get as an infusion reaction may be related to CD38 on basophils. And with the Montelukast, you can often eliminate a lot of that. So unless they're really bad COPDers on oxygen, I'm going to go ahead and do what I suggested earlier on.
Next question here is, do we have enough data to use MRD to make a decision about a second transplant? And that's not an area that we have a lot of data on. We actually don't have a lot of data about even first transplant and MRD. So that's the answer there. Sagar, can you re-challenge with an antibody during relapse if DARA, I think, was given up front, which is a big question.
Yeah, I think that's a great question. And we actually, in that paper that I showed you that's in press looking at POM-DARA early on, we had 3 cohorts of patients. Cohort 1 was naive to both. Cohort 2 was exposed to either POM or DARA. And cohort 3 was exposed to both POM and DARA before they got treated again. And the patients in the double exposed group did respond. The median PFS was a little bit shorter. What we found was that if you wanted to maximize the chance of a second response, giving them a drug holiday between the first exposure and second exposure to DARA of about 3 months was increased the chance of responding a second time.
Next question here is, would you consider stopping or not doing maintenance in an MRD negative patient? And at least for me, the answer right now would still be I would not stop, because we showed you the curves that unfortunately even people in CR and MRD negativity do relapse, although they do so more slowly than if you're MRD positive. So I think with the sensitivity of the testing that we currently have, we probably should not yet be stopping. Maybe in the future with either more sensitive, or if you have people that are recurrently MRD negative on multiple assays, that may be a consideration.
Yeah, and I agree. I think that's a really important point. The idea of subsequent testing for MRD negativity. If you're MRD negative at cycle 4 of induction therapy, I have no idea what that means. Whereas if you're MRD negative at 1 year and 2 years post-transplant, that might mean something different, and we don't know that yet.
And then Sagar, this will be for you since you have some of the data in this area. In high-risk myeloma, you recommended VR maintenance after transplant. What is the evidence that VR is better than either V or R alone?
Yeah, so we published this data a few years ago. Dr. Nuka was the first author in leukemia, so it was VRD actually for 3 years. And in that, our PFS was, I think, about 36 months, which is much longer than you'd get with V alone or R alone in a high-risk patient population.
And there are the data from the Dutch and German study where they did VAD transplant and thal maintenance versus bortezomib, Dex transplant and bortezomib maintenance. So it's not quite R versus V, but it was kind of T versus V, and the V was much better. Those are all the questions that we have from cards. I don't know if folks have questions that they want to come up to the mic and ask.
All right. Well, again, thank you very much for your attention, and thanks to Bob for a great presentation, and have a great meeting.
All right.
Bye.
This activity has been jointly provided by the Medical College of Wisconsin and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/QAJ. This activity is supported by educational grants from Adaptive Biotechnologies, Celgene Corporation, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, Takeda Oncology, and Sanofi Genzyme.